Good afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Before introducing today's speaker, I just wanted to make some brief announcements. Please take a moment to ensure that you're muted. In order to receive CME credit for attendance, please see the chat room for instructions. You need to sign up to get credit, and if you have not signed up already, please send a message to Debbie Lovejoy. And if you think anyone else is interested in joining, you can reach out to her as well. And if you have any questions or comments during the presentation, please use the chat room, or you can also unmute yourself at the end and ask questions on your own, and I will moderate the session. Recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And today I have the real pleasure of introducing Dr. Alejandra Lastra. She is currently an associate professor of medicine at University of Chicago. Dr. Lastra directs the Sleep Medicine Fellowship and the Advanced Respiratory Care Program at the University of Chicago. She's also the associate medical director of the University of Chicago Sleep Center, chair of the AASM Education Committee, and immediate past president of the Illinois Sleep Society. Her expertise spans with hypercapnic COPD, morbid obesity overlaps, home invasive and non-invasive ventilation, and complex sleep disordered breathing, including neurostimulation. And she's also recently, about a year back, started a phrenic nerve stimulator program at her institution. Recognized for her contributions to education, diversity, and research, Dr. Lastra has also authored numerous peer-reviewed publications and has presented at national, international conferences, which are extremely interesting, and many of which I've also attended, and they're excellent. So if any of you attend any conferences in the future, please make sure to look out for her presentations. And she's also mentored numerous trainees. She holds fellowship with the American College of Chest Physicians and the American Academy of Sleep Medicine. Thank you so much for being with us, Ali. And without further delay, I would like to hand it over to you to share your expertise on the future of CSA, integrating sleep, heart, and technology.
Thank you. Thank you so much for the intro. I'm showing this for disclosure. I'll keep it there for a couple of seconds. And I'm going to start with a video. I was rounding with my pulmonary fellows. We were called for hypoxia on a patient in the CCU. It's a little bit blurred, but she's sitting in the chair talking to us, just chatting. And so my fellow takes the oxygen off. It's like, oxygen is good, you don't need it. And then all of a sudden I see, the stats drop to like the 80s. So then I turned to my fellow, it's like, the stats dropped. And he's like, well, it was not a good signal. It's like, I'm pretty sure it's a good signal. And then as he's going to like troubleshoot the oxygen or the saturation, I said like, wait. And then we recorded what the respiratory pattern was on this screen. So she's awake, she's looking at us, and she's completely apneic. And then she has the crescendo pattern. I don't know if I was able to share the sound, but I made this like dramatic noises too on the different screenshots. But you see, the oxygen desaturation is delayed compared to the apnea and the hypopnea. And this is what we see in Cheyne-Stokes respiration. So, this is Cheyne-Stokes breathing in an awake patient. So from our disorders, Cheyne-Stokes is the one breathing pattern we can see in wakefulness. And so we're going to review indications for diaphragmatic pacing for central sleep apnea. This is not for ventilation. We're going to talk a little bit about the mechanism of action and clinical pathways that we're implementing for these patients here. So in the central sleep apnea groups, there are hypocapnic and hypercarbic. So the hypercapnic central sleep apnea disorders, I always want to remind people, obesity hypoventilation is a hypercapnic central sleep apnea disorder. The hypocapnics, the classic one, high altitude, of course. I don't deal with that too much because I'm at sea level. But heart failure is another kind of very common cause of hypocapnic or eukapnic central sleep apnea disorder. And so within the groups, there are groups that just have a decreased ventilatory drive, like they won't breathe. And that's the example of obesity hypoventilation patients, or like in pediatrics, congenital central hypoventilation syndrome. And then there is worsening mechanics, like they can't breathe. And these are the example of like myasthenia neuromuscular disorders. And so that's kind of like part of the classification. And I'm going to start with a case. So we have a 79-year-old male. I actually just saw in the clinic today, heart failure with reduced ejection fraction, 47%. Parkinson's disease, has a deep brain stimulator. Has clinical RBD, no PSG, but has some dream and acting behavior, very active sleep. Is a Vietnam veteran and has a history of PTSD. He's presenting with these symptoms, which are classic for sleep disorder breathing, and like correctly so, the pulmonologist that is in him for evaluation of shortness of breath referred for a sleep study, which showed severe central sleep apnea. In discussing with him, he has pretty profound claustrophobia, PTSD, and he said like there is no way he's gonna ever put any mask on his face. And so for this case, when we're talking about remedy, which is the implantable pacemaker for central sleep apnea, the questions are, well, he's not eligible because of his age. If we remember, I think he was 79. We should proceed with pacing, but we have to remove the deep brain stimulator. It's there in similar areas implanted of the chest. He's not eligible because he has not trialed and failed PAP, or we should just proceed with pacing and keep his deep brain stimulator. So we're gonna go back to this case after we review some of the literature. So high altitude, I love when national media like makes any awareness about sleep disorder breathing. So there was like kind of like claim of this during Obama's awful debate. I remember watching this and being like, what's going on with this guy? And occasionally, in Chicago, we'll have patients that go to their houses in Aspen, and then you have a spike of events. And this is something that I'll teach my fellows, like get the 365 download data and ask questions, right? It's like, what happened here? Like, did you have surgery and opiates? Did you have like a heart failure exacerbation? Like what happened? He happened to have a house in Aspen, and so he would travel that. And those are central sleep apneas triggered by high altitude, and we could, track on the PAP machine. And then we have this other example. It's like this is the log of a titration from beginning to end, and you see that it's obstructive, 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 like almost all the way. Few centrals, but majoritarily every event is obstructed on the diagnostic portion. CPAP is started, and then the events start becoming centrals and obstructive, and then centrals. And at this point, CPAP continues to be increased, so increased for respiratory events, increased. And at this point, it's all central events, switched to BiPAP at very high pressures, and ultimately ended on a BiPAP of 20/15 with persistent events. So this is treatment emergent central sleep apnea. I usually, will joke with my fellows that this is either Herring or Bauer looking at you like you're gonna continue to increase the pressure. And it's we suspect it's like a barotrauma protection. So there is like mechanoreceptors in the lungs, and with the stretching and the pressure, they get triggered. So the response to treatment emergent central sleep apnea titration study should be to decrease the pressure. The truth is that there are some cases that persist, and then we need backup rates to treat that. In a percentage of patients may resolve over time, and that's why the ASM recommends to, even if you have a PSG that suggests treatment emergent centrals, put them on CPAP and then monitor the data over time. When they persist usually in higher risk patients, and it's related to this barotrauma response. This is one of such patients that was put on like low pressure PAP, and you see that the respiratory events are trending down without any changes in settings. So for this percentage of patients with treatment emergent centrals that improve over time, then it will go away with CPAP. And in the group that persists and they're symptomatic, you may need to do additional treatment interventions. The opioid CSA, in my experience, is very hard to treat. The answer for the board is always, decrease the opioids as much as tolerated, use alternative therapy, but we all know in reality that may be like difficult to accomplish in patients with chronic pain syndromes. And so when we see central sleep apnea, they're usually more ataxic breathing, so a couple of breaths, then starts and not decrescendo breathing pattern. And in patients, if they're having sleep fragmentation, hypoxia, and hypercarb and like daytime function impairment, then we would recommend treatment, usually BiPAP with a backup rate, or ASD could work. And I have few patients with Remedy, which I'm going to discuss. So in cardiovascular disease is very interesting. We were running a trial along with like an industry sponsor registry, and the trial was stopped because there was it was very difficult to recruit patients for this study. And the study focused on heart failure patients with central sleep apnea that were going evaluation and were being treated with Remedy, which is the diaphragmatic pacer. So out of 10 heart failure patients, 70% or more will have some form of sleep disorder breathing. And, a proportion has regular bread and butter obstructive sleep apnea, but a big proportion of them also has central sleep apnea. And so for my cardiologists in the group, and I've been to, my cardiology colleagues also to like increase awareness about this. I think our EP cardiologists are excellent at screening for sleep disorder breathing because of the atrial fibrillation and the risk for recurrence and obstructive sleep apnea. In the heart failure population, we have had a little bit of difficulty getting those patients into evaluation for sleep disorder breathing, whether it's obstructive or central sleep apnea. So these are points where those patients can be captured for evaluation. Symptoms are, as you see, fatigue, nocturia, awakenings. Many of them can be gasping for air. And recurrent hospitalizations, which is a big deal, of course, and like it's a big burden. But it is from the symptomatic standpoint, sometimes it's impossible to really tell whether it's going to be obstructive or central. So you need testing. And the symptoms can be very similar and indifferentiable between the two, obstructive or central. So we need this sleep study. But what we know is that if you have those patients with central or obstructive sleep apnea, they have worse survival. And if when the sleep disorder breathing, it's like not there, then those patients live more. So it's a big deal. It affects hospitalizations, quality of life, and mortality. And treatment seems to improve these outcomes. And specifically in the heart failure population, the presence of central sleep apnea or obstructive sleep apnea increases risk of ICD shocks. And so why does central sleep apnea happen? The pathophysiology is super interesting. One of the hardest things that I had to learn in fellowship, I think. And I'm going to try to explain it the way I understood it. So there is, when you're awake, your volitional drive to breathe is there. Like people can hyperventilate to alkalemia to that point, right? And you control your breathing with swallowing, with eating. It's pretty impressive. But when you fall asleep, all the volitional, emotional, like all the drives to breathe are out immediately. And there is the appearance of an apnea threshold. So the apnea threshold is there like as a safety guard so that you're not hyperventilating in sleep. And so in someone that has a normal response, and again, I'm not sure if you're hearing this sound, but this is an iPhone alarm clock, which already gives me like tachycardia. So there is a disturbance. It could be the dog barking or whatever. And the natural response is that micro awakening, and increasing the tidal volume. So you're breathing deeper breaths, the CO2 goes down, but it doesn't get to that apnea threshold. And then you go back to your sleep apneic CO2. Over time, the CO2 doesn't need to be maintained at 40 perfection. So it will drift up 4 or 5 points. So this gap will increase even more. So you'll have more cushion to not get to that apnea threshold. And this is why sometimes, people do have sleep onset central apneas. Those are physiologic. It's like you're still haven't buffered this difference enough at the beginning of sleep, but then it goes away. And then patients with central sleep apnea, let's say it's a heart failure patient, or other of the central sleep apnea patient populations we saw. There is pulmonary edema, they're in heart failure, their Golgi tendon organs, which I know you remember from med school, are here, and they're feeling this stretch. So that triggers an apnea event. The juxtacapillary or J receptors are also mechanoreceptors in the lung, feeling this stretch, and as a barotrauma response will trigger a central apnea. And on top of that, because of the slight hypocapnia, they tend to be have a very narrow CO2 reserve. So the same stimulus of the alarm will cause the increased tidal volume, which in many of these patients is even exaggerated. So it's like a next too much of a response to exaggerated response. And that will take them under the apnea threshold. And because of the slow circulatory time, by the time the body, that blood gets to the chemoreceptors in the carotid bodies, it's been too long. So that hyperpnea, like this apnea response has been going on for too long. And then the response is exaggerated. And it's almost like when a car without suspension falls on a pothole, like they'll go into this periodic breathing. And that's part of the pathophysiology of the central sleep apnea periodic breathing. So the mechanoreceptors have to do with it. And that's another reason why central sleep apnea can worsen in supine sleep, which is always like a fun question, trick question for the fellows. And it's part of it is because there is fluid redistribution to the upper parts of the lung as well, and it stretches a bigger proportion of the lung, so it triggers more centrals. And so this is kind of like summarized and all of that, and obviously that increases the stress on the cardiovascular system and worsen outcomes. So this is like that periodic breathing. So you see it here, patients are awake, and there is this is a screenshot of a sleep study, eyes, EEG, EKG, snoring, and this is a patient on PAP therapy that we're monitoring the airflow in and out, chest, abdomen, and oxygen saturations. And you see that there are these pauses and there is no breathing, no effort. Those are central apneas, but the patient is awake. And then when they fall asleep, then the centrals become more like evident and longer. The longer the apnea period from here to the end of the hyperapnea, the lower the ejection fraction, which kind of makes sense. And these guys here, this little bump in the flow channel, these are actually like heartbeats that are transmitted because the airway is open. It can be detected by the flow channel at the mouth level. So that's also like super cool to see. And in REM sleep, the central sleep apneas tend to resolve. So that's another clue, like when it's difficult to differentiate between obstructive and central. And usually the arousals, like the awakening that happens, doesn't happen like right here, like in obstructive. It happens in the middle of the hyperpnea. And so those are all like also clues. And you see, if you see like there is like no breathing, and then there is this very fast chest abdomen movement that happens. We can also capture it on home sleep testing. And so you'll see like this is a flow-based device, it's the apnea link that is not available anymore. Another characteristic of central apneas are that the oxygen desaturations are more symmetric. So as it drops, it comes back up and drops, comes back up. In obstructive sleep apnea, more like a check mark. So it drops slowly and then it recovers fast. So those are other cues that we use. So what's the big deal? You know, we've been talking all this time about the different types, the pathophysiology, like what obviously, you know, the relationship with other comorbidities. But the other part of it is that the treatment for central sleep apnea is relatively limited. We have PAP therapy, so positive airway pressure. CPAP has really not shown a mortality benefit for the treatment of central sleep apnea. BiPAP, we don't really know, and this is even for heart failure patients. the adaptive servoventilation, which is a BiPAP with a backup rate that self-adjusts and treats central sleep apnea beautifully, by the way, it showed increased mortality in patients with ejection fraction of less than 45%. And we don't know why there were these theories, maybe that chain stocks was protective for heart failure patients because when they're not breathing, they're using less energy. But there is also like this concern that bi-level PAP, the two pressures and the backup rate, actually may hyperventilate some patients, get them hypocapnic, and then they end up having more arrhythmias. So it may be related to the positive airway pressure. There is also some of them are preload dependent, and positive pressure in the chest can change the hemodynamics of in patients with very severe heart failure and RV dysfunction. So there's still a lot that like we don't know, but to be honest, especially in heart failure patients with low ejection fraction, it feels very uncomfortable to to treat the central sleep apnea with PAP therapy. Sometimes we use low level BiPAP with a backup rate. Oxygen can improve periodic breathing because then they are not hypoxic, they don't get into this semi hyperventilation because of the hypoxia, and they don't have that close relationship to that apnea threshold that I showed. But there is no way to get insurance approval for oxygen for central sleep apnea because the one trial that was being run on sham oxygen and oxygen therapy was actually stopped funding because of the recruitment was slow. So we don't have that. This is the one like trial that is the SERVE-HF that showed the increased mortality with adaptive servoventilation, which is that BiPAP with a backup rate. And then we were waiting for years. I was waiting for like 10 years since I graduated from fellowship for the ADVANTAGE-HF, which was another trial that had to be stopped because of the SERVE-HF. They had to reconsent all the patients. Then they had a combination of obstructive centrals in patients as well on a different device of ASD. And then ultimately, then they had the COVID pandemic. And then after that, they had the recall of Philips Respironics. So this study was not powered to determine for sure if it did increase mortality risk or if it was safe. A lot of like safety interval analysis seemed to demonstrate that it was safe with this other different device that is a Respironics ASD device. But then ultimately, we don't really know for sure. And there is a black box warning for getting an ASD for anyone with heart failure. So these patients, I feel like, are not being referred. It's like people don't know what to do with their treatment of central sleep apnea, so it's not being addressed. So another case, 68, hypertension, ischemic cardiomyopathy. You have all like symptomatic, and then you have the PSG that showed severe sleep apnea, based like predominantly centrals, and nadir oxygen saturations in the 80s. So what would be, I guess this is the PAP trial. You do CPAP 5 to 18, there's no improvement. And then ultimately BiPAP without a backup rate is implemented. And there is a low residual AHI. So from here, what would you recommend for therapy choice? So you go with the CPAP trial, you do the BiPAP, you put them on ASB, you try phrenic nerve or no therapy. So no therapy is not an option, like patient symptomatic and pretty severe sleep disorder breathing. ASB is contraindicated. So it's that question of like, should we go for PAP or should we go straight to phrenic nerve stimulation? And at this point, I think most of us will do PAP therapy, right? It's cheap and it's non-invasive, and it will work in some patients to improve their quality of life and symptoms. And so BiPAP was started, and the patient was adherent, but difficulty, and ultimately, despite good support, could not tolerate. So then at that point, is when I think we would consider an implantable system. The pacer is very interesting. So I know many of us are already very familiar with Inspire. So Inspire has that remote control or the Genio device that requires that you activate, like the patient has to turn it on and turn it off. And then it like synchronizes with the breathing. For the pacer for Remedy, it actually doesn't have an on-off button. So it turns on in a time window that you set with the patient, that is your sleep window, and then it will turn on when the patient goes beyond head of the bed elevation. So when they're laying flat and if they're not moving. So that's wonderful in a way because it removes a little bit some of the adherence compliance like requirements. Oh, I forgot to turn it on. I didn't turn it on because it's more like within the time window if you're laying down. And that's how it will get started. So it starts automatically at night, but it's really like that time window that you set for the patient. So between today, we set a patient between midnight and night in 9 in the morning. That was his sleep window. And then the level at which they lay down, because then my next question to the remedy people was like, oh, but like these patients, many of them are sleeping upright decline, like because they have orthopnea and they are sleeping with 3-4 pillows. So how is the device going to get activated? You can actually adjust the pitch, which is like that angle at which the patient like has to go down on like as for that device to get activated. So it can be personalized to the patient. Just actually I found like fascinating. And then other than that, it has like a stimulation lead, and the stimulation lead is also interesting. So this is the device that it goes implanted similar to a pacemaker pocket. The lead gets cannulated in the vessel. That's why the implanters are cardiologists, because they're very familiar with the technique. And the vessel preferentially is on the left side, and like on the right side, the SVC or brachiocephalic trunk. And these are vessels that are running next to the phrenic nerve. So you see like the graphic here. And so they stimulate one side. They stimulate one side of the diaphragm, and then they recruit the other side. And so in the initial like pivotal trial for effectiveness, these are the characteristics of the patients recruited. So it needs to be moderate to severe. They use an AHI of 20, but it's not a central apnea index. You notice that many patients had quite a bit of a component of hypopnea. And that's crucial because not all of us are scoring central hypopnea, right? It's optional, they're hard to score. So many of them get scored as obstructive hypopneas. So many of those patients had like a not unreasonable hypopnea component, and they were actually patients with some comorbid mild obstructive sleep apnea. And what they show is that, it's effective, like turn it on, it paces the diaphragm. It's not in sync, like waiting for the breathing, right? These are patients with periodic breathing. So they have like unstable breathing patterns. So it will just pace at a 12, 14, whatever rate you set. And it's usually set like 2 under the respiratory rate of the patient. So the sensing lead is there to give us data on how the patient sleeps, position, what pitch do they sleep at, what like the AHI or like periodic breathing index capture, but it's not sensing to synchronize with the breathing, it's just pacing. And then the follow-up trials have shown that the effectiveness is actually sustained over time. And so when you compare to cardiac pacing, it's more like a pulse that increases and decreases with during inspiration to try to stimulate like that activation of the diaphragm. And then you'll have like, it will activate at a period of time that is fixed. And so the primary target vessel, I always like add one extra word to this one, but it's the left pericardiophrenik vein. I usually add a costa there, I don't know why. Pericardiophrenik vein is this little vein that is here. So it's difficult to cannulate. You need a good and like cardiologist. So this is the accessory hemiasticus, and then there is the internal thoracic that runs next to it. So they have to do like the contrast to figure out to kind of be able to cannulate this vein here. And this is an example, like at the anatomic level, you see like the phrenic nerve and the pericardiophrenik vein, how they run so closely together. And this is videos for the catheterization part. So they'll essentially kind of like cannulate the vein and then shoot the contrast and try to see that beak, because like that entrance to the vein. And in some of the cases, they have to decide if the vein is the appropriate vein to cannulate. So like in this case, this is actually the internal thoracic vein. So they couldn't cannulate this vein, but this is actually like that deployment in the proper vein. So they have to be careful about the vein, and this is how they deploy the lead on the left side. So if the left vein cannot be cannulated, then we talked about the right side placement. The right side placement actually needs a new lead. It's not the same lead. It looks almost like a piggy tail. I hear you see it. So it's coiled. And it's coiled because it's a bigger vessel. So it needs to kind of like get to the sides of the vessel to get close to that phrenic nerve. It has more electrodes, and it does take longer to mature, and it does use more energy. So the battery life is less. So that's why the left lead is the like preference. And this is what that lead looks like there, from the device to the placement in the vessel. So there is a significant clinical need to treat central sleep apnea in patients with heart failure. It improves symptoms and it treats effectively the central sleep apnea. And then, obviously, having a good implanter that just doesn't give up on the left side very easily and just goes on the right for ease is important. And so we put together a program with Dr. Padier, who's the electrophysiologist, and now we're recruiting a second implanter. You do need to have good buy-in from cardiology. I think it's a profitable program for EP, and I say this because when you're launching programs for the hospital, this is something you don't learn in fellowship, but they want to see the money, right? Is this going to be a good program for the hospital overall? And I think it proves that it is. There is some additional like billing codes that we built in to make sure that it's a successful program for our patients. And then obviously we have our whole sleep medicine faculty that evaluates these patients and refers directly to Dr. Padier for implanting. So he kind of like makes sure that the implant is safe and doable, and we make sure like that it's actually indicated and appropriate. So we created some pathways. There are several pathways or points where these patients can be referred for pacing. So at the sleep study time, if it's a predominantly central sleep study, I would say that even though watchpads are approved for central sleep apnea diagnosis, if there is a central sleep apnea diagnosis and I'm going for remedy, I usually confirm with PSG before we implant. And then although it's not like a requirement for the device itself. And then we diagnose, we do a PAP trial. If they're not being successful with a PAP trial, like BiPAP ST or ASD, that's another point where they could be referred for the program. And so we worked actually with outside like referrers, because we're one of the only centers in Chicago that is implanting. And that's also important, is you need to have like good volume to like keep your implanter at a good like competency for like doing this in the right way. So we put a dedicated call line. We have a dedicated email, and a nurse that helps us make sure that these patients are going to the right like pathway with Dr. Patty. If someone has seen a sleep specialist outside, like one of the academic centers, like I don't generally don't need to see that patient again. They can refer directly to the implanter, but the activation happens in the sleep center, and that's why I created a dedicated clinic, because these activations can be an hour and a half long. So there's no way I could have fitted this in my regular like sleep clinic day to day. So we have a dedicated last Friday of the month. I schedule all the patients, and we have the Zoll tech that also comes. We have a programmer, and we work together on like the activation and the implantation. Um, so that's kind of like lay down in that initial consultation. There is a prior auth that is shared between sleep and cardiology, because we put the sleep study data. Our sleep study data is not easy to kind of like take out if you're not familiar with sleep medicine. So we make sure like the central sleep apnea index, the central hypopnea index, everything is logged accurately, and then cardiology finishes like the rest of the prior auth. It's in a website. And then the patient gets scheduled for the implant. It's left to heal for about a month or two, and then we schedule the activation. And so during the activation, we get the information also on how low the patient sleep, what's the HI, and the sleep weight. It's almost like an actigraph data where you get like the sleep times, and we adjust the therapy, personalize it to that patient. So that's what that looks like. There is a wand that connects to the device. We get the data on the like the remote, the tablet, and then you get information. Then after that, I need to follow up on battery life, capture, and like efficacy. And this is an example of the activation. It's a video. So what you'll see is, because it's a one-side unilateral activation, when we activate it with the programmer, the patient feels like the diaphragm contracting, so it feels like a tug. And you'll see that there is a bigger breath that happens. And you want to make sure that there is no like extra respiratory symptoms. Sometimes they feel activation on the neck or the shoulders. So then in that case, the electrodes are kind of changed so that it doesn't go into the neck or the shoulder. So this is that video. So she's gonna breathe in, that's her. Breathe out, that's her. And that's the activation. That's the breath. And if you look carefully, you can actually see a little bit of a wave from one side to the other. Breathe in, that she does that. Breathe out is her, and activation. That's the activation. So she was very comfortable with the device. And this is what her device looked like. She's a skinny patient, so you can see the device and the chest, like the well-healed scar, but it kind of pops up a little bit. And she did have a right-sided lead. And then we follow up with the sleep study. This is a sleep study for that patient. And it actually, it's a smaller number of patients, of course, but it's been pretty effective in our patients. This is not IPAP, EPAP. We still don't have like I think the technology moves faster in some ways than others. So like we didn't put like the amplitude. This is like actually like the amplitude in the different electrodes configuration, the cation and the anion. So that's what that is. And then I create a report and say like, this is the combination of electrodes that work best, and this is the amplitude that worked best. And then it's also adjusted for position. This same patient sent an email after saying that her life had completely changed. She has chronic pain syndrome, so she needs like intrathecal opiates and baclofen, and so that's part of her central sleep apnea disorder. But she was able now to interact with her family, and she was just like over the moon after the therapy was activated and she was effectively treated. So it was very like reassuring to see good outcomes when you're doing this kind of invasive, expensive interventions. And she had trial PAP and couldn't tolerate no matter what. So, and then after a while, she started developing some more noisy breathing. She was feeling better. She actually gained some weight. So I was worried about obstructive sleep apnea because the contraction, the passive contraction of the diaphragm can kind of tug the upper airway. And there's some reports of treatment emergent obstructive sleep apnea after remedy placement. So I did do a home study, and it showed effective treatment and no obstructive sleep apnea. So we're monitoring for that. And so even though, Remedy, I think, was like started with a lot of enthusiasm to be a main treatment intervention in the heart failure population, what we're seeing really is that those patients are not being referred as much as we know, like the prevalence is there. I don't know if it has to do with like the advancements in LVAD placements or like heart transplantation, but we're seeing it more in like CSA, secondary to opioids, altitude, even treatment emergent central sleep apnea. Patients are willing to have this treated and then being able to use low pressure PAP. Like they're okay to that, but they cannot tolerate like high pressures and backup rates. And I was wondering if I had time for this. I'm gonna go kind of like
Yes,
fast,
you
but
do.
this is a patient. I do have time.
Yes.
Or
It's
okay, okay.
15
This
minutes,
is
so
this is a very interesting case. Like they watch, but actually had severe sleep apnea, majority centrals. We have a philosophy of not believing the watch pads in these cases. So they actually, the patient had a baseline PSG. The baseline PSG had a ton of central hypopneas that were scored as obstructive. So you see like the arousal is in the middle here. There is really no a lot of snoring. The snoring or noisy breathing happened in the middle, but yet they were scored as obstructive events. And so ultimately, did you see they go away in REM, which is another clue that they're centrals. Patient gets sent on a CPAP after that split study or baseline study. And then you see that continue to have high HIs and periodic breathing. And the auto kept the pressures low because they were mostly central events. So after a year or so, patient is still symptomatic. We say, okay, this is central sleep apnea. We need to treat with ASV. I treated with ASV, beautiful titration. If ASV does something, is treat the centrals well. And then I couldn't get this patient the ASV. And the reason was the PSG would have called this like treatment emergent and you needed to show BiPAP S failure. And so we had to go back to the PSG study, rescore all the events, then show that the majority are centrals, and then he got approval for the ASC. So in that case, the watchpad was right. The scoring of the PSG manual scoring was wrong because of that optionality of scoring hypopneas as centrals. And it took 2 years to get this patient on like an effective like therapy because of that. And I think a lot of patients are not, being considered for these more invasive interventions because the central hypopnea scoring, it's not there, right? And so it's underestimating central sleep apnea events. So I encourage you to score central hypopneas and kind of like keep that in the back of your mind. This is another patient I just added, but this is back to our patient, our index patient. So this is the sleep study. You see that there are like this crescendo, like central apneas that are happening. They're also happening in wakefulness. And to be fair, he did have a ton of wakefulness. I was wondering, it's like, oh my God, what are all these DSATs? But it's because he has periodic breathing even in wakefulness. We know now, the results of that case. This is the summary of the hypnogram. And this is the chest x-ray with the deep brain stimulator placed. So he has a DBS for Parkinson's disease. And the patient's like, there is no way you can get a mask on me because PTSD. So we actually, there's no age limit Um, and there is no requirement to try and fail PAP for remedy placement. So you don't have to do that necessarily. We do it in clinical practice because it's the right thing to do a lot of the times, but it's not an insurance requirement. And in this case, it was not appropriate for the patient. Then there has been patients implanted with multiple devices, so AICDs and Remedy, or in this case, DBS and Remedy. Our cardiologist felt uncomfortable to place both devices on their right chest. And so what we did is we implanted the Remedy on the left side, and then the lead was cannulated, like tunneled, and then placed on the right side. So that the two companies were in the OR, the representatives, to make sure like they test intraoperatively to make sure that there is no interference, electric interference between the devices, which went okay. And then now that's the patient we were activating today in the office. And I took this picture with his permission, and he knew I was presenting now. So this is the wand, and we activate on the back, on the left, the right side. So we test the electrode positioning and the setting. And so now he's going home with that device and hopefully improvement of symptoms. He's quite symptomatic. So that's what I have. I have some time for questions. And I just, want to thank our sleep center here and our cardiology team for the support. I love this slide because it says, raise your hand. The joke was like, raise your hand if you don't know how to swim. So if I'm open for questions, and I'm gonna stop sharing here.
Great. Thank you so much. This was excellent. Amazing talk, Ali. Especially
Thank you.
this topic with difficult technology and sharing this thorough information on your program. So really appreciate it. So if anyone has any questions, please feel free to type here. I have one question here by Daniel McNally. In heart failure, besides J stretch receptors and muscle stretch receptors activated by lung stiffness, what other factors might contribute to increased loop gain? Is there a genetic predisposition?
So I think a big part of it is that the patients tend to be hypocapnic because they are hypoxic. So they're hypoxic, they're hyperadrenergic drive. And so they tend to run PCO2s like 34, 35, 36. So the minute they fall asleep, they're really close to that apnea threshold, and anything takes them under. There is also evidence that like this rostral redistribution of fluid, especially when they lay down, can also increase edema of the upper airway. And the upper airway also has mechanoreceptors. So when it gets deformed, like it also triggers central sleep apnea when the pressure increases. And there is, there's a lot of work being done on endophenotypes for sleep disorder breathing, even in obstructive sleep apnea. So I do think that there is a group of patients, like there is a genetic predisposition to a low arousal threshold. So they're just like more hypersensitive. Interestingly, we had a patient with a very low EF. I think it was 10%, something crazy. My fellow who does the order of reconciliation, who's excellent fellow, he's still like regretting this, but like the patient was on a Milrinone drip and he didn't catch that. So the patient came on a Milrinone drip to the PSD sleep center. And this patient had horrendous, like obstructed centrals, but he was also morbidly obese outside of Chicago. So he was actually hypercarbic and he had obstructive sleep apnea. He didn't have centrals. And we were debating. I was talking to Babak, my class, about like this case too. And it's like probably that hypercarbia from OHS protects him against that periodic breathing because then he has more cushion. And so that patient was titrated to very high BiPAPs, and the more the BiPAP went up, the more the hypoxia worsened. So thankfully, he survived our high BiPAP titration. So we put him on a low CPAP dose, and he's doing okay.
Hmm. Interesting. Another question. Have you used this with unilateral diaphragm paralysis leading to hypoventilation in REM?
It's not, no. The answer is no. Don't use it. It's not for hypoventilation. There are diaphragmatic pacers for hypoventilation that are very different than how remedy works. And they tend to be like more 24/7. So it's not approved for hypoventilation. So if I see that, that's an exclusion.
Thank you. Another question by Stuart Mann. In those patients with Cheyne-Stokes breathing who do respond to CPAP, what's the proposed mechanism?
Um, so I don't think we know, and that was one of the criticism of the CANPAP trial. It was like, okay, what pressure, like what are we doing here? But I do think that part of it is the stenting of the upper airway and stabilization of the upper airway, the improvement perhaps in a little bit of like pulmonary edema from the PAP pressure, although I don't know that that's so immediate, but perhaps. And I do think that some of these patients have a little bit of combined obstructive central, so it prevents the post-arousal centrals that happen when the airway starts collapsing. So I think that's why 40% of patients with centrals actually respond to CPAP, which makes no sense otherwise.
Yeah, probably the same rostral mechanism. Yeah.
Yeah.
Finally, so what are the main predictors of failure or success, for remedy and like, overall we're talking back, like, what's the success rate data on remedy? And if people have both obstructive and central,
Yeah.
many questions.
The data, so again, the data shows it's very successful. I can't remember the actual number. I'm really bad with numbers, but like the great majority of the patients responded. This is in clinical trial settings with highly selected patients, right? But when they were, and it's sustained at 5 years, so the effectiveness has been sustained. When the patients have residual events, they tend to be hypopnea. So
Mm.
the hypopneas may persist. And I think that's what we're gonna see. It's like it's not gonna be perfect, but it's going to be better, and that's what the I think it's being seen in clinical practice. That was the part of that registry to have more information, but I think the recruitment was low overall. But effective to treat central, sustain over time. Hypopneas tend to uh, remain, and tolerance overall is good. It's like it hasn't had like a lot of side effects or like patients needing device removal, because it can be adjusted over time for tolerance. It has some ramp features, and the amplitude and the electrode configuration can be adjusted. I think more to come. The other interesting question is, are these patients going to survive? Like, is this going to show no mortality increase in Cheyne-Stokes, which is expected, right? We would expect if we treat Cheyne-Stokes, they do better. And it's not a protective mechanism. So we'll wait for that data.
More to come on that.
More to
Um,
come.
the next question I have is from Ian Weir. Do you ever try nocturnal oxygen to treat central sleep apnea, chain strokes? If so,
Yes, yes. If they have oxygen qualifications by any other mean, or if the patient can buy it, which is not my Southside, that's usually Lisa Wolf at Northwestern being like, "But your daughter high from?" Like, that's your patient that can buy it. Like, my Southsider is poor. So the challenge is insurance approval. But if we have approval for other reasons, they left the hospital with a box or whatever it is, I may try and use it. And you do see improvement in periodic breathing and centrals on sleep studies. So I have a patient that cannot tolerate PAP, and he's on nocturnal oxygen.
how do you approve it? I think that's the biggest thing. Like there was one patient,
Just for other things.
yeah,
Yeah, it's not approved for centrals for sure. No way.
yeah, there was one patient who just bought, okay, I'll just buy it. So sure, okay.
Yeah, those are the Northwestern patients.
All right. Well, I have one more question here from Toshita. Where is Remedy available around us? Is Yale doing this yet? Not yet. Yale is not doing this yet. Not sure. I'm not sure if Connecticut, any program is doing it here. But
I know that a lot of the programs in like Denver, the high altitude states are doing it, but because obviously they have a high prevalence of central sleep apnea. But it is, I think the challenge is obviously getting the device paid like with the hospital administration in stock, whatever that means, and having a cardiologist. Like I wanted to get the program started at Rush when before I moved to the University of Chicago several years ago, and I just didn't have an EP that like bought in, so I could not get it off the ground.
yeah, you just have to have a well-designed program, and I think Northwell is a, yeah, probably, not quite sure. Um, if anybody else has any other question, please feel free to unmute yourself or you can type it. If not, we have 2 minutes left and we can end it.
I was nervous because I added some pictures at the end. I always get in trouble when I do that.
That was great. I think, adding that. All right, looks like we don't have any more questions. Again, thank you so much. This was amazing. I think the field is again, going in a different direction. Like we talked about, since we have all these debates still ongoing about the devices, I think, Remedy is really a good option to have, I think. And
Yeah, and I forgot to include the new central sleep apnea guidelines, but it's now in the guidelines after trial and path, of course, which I think makes sense.
right, yeah, yeah. More to come on
All
that.
right.
All right, thank you so much.
Thank you for the invitation. I really appreciate it. Bye.
Thank you, everyone. See you next week. Bye-bye.